Long anterior zonules are anterior zonules which are inserted beyond the normal insertion on the anterior lens surface, leading to a small zonule-free zone. They are present in about 2% of the population. However, sometimes they are subtle in appearance and may be missed on slit lamp examination. The trick is to look for them in retroillumination. They stand out clearly against the red glow. Another trick is to look at them under high magnification and bright light. They have a wide phenotypic spectrum. They may be pigmented, segmental, complete, or mixed. The size of the zonule-free zone is variable. So what is their significance? Eyes with long anterior zonules have multiple ocular comorbidities. A careful examination is required to help in identifying these comorbidities. They are associated with pigment dispersion and have pigment on the anterior lens surface, pigment deposits on the LAZ themselves, pigment on the posterior corneal surface, and a Krukenberg spindle. Due to this, they are often mistaken as eyes with pigment dispersion syndrome. These eyes need regular intraocular pressure monitoring, as increased IOP has been reported in these eyes as compared to normal eyes. It is important to perform gonioscopy in eyes with long anterior zonules, as angle closure disease, including plateau iris and pseudoplateau iris, has been reported. Indentation gonioscopy is recommended. Ultrasound biomicroscopy helps in understanding the pathophysiology of angle closure in these eyes. A subset of LAZ eyes are hyperopic with thick lenses, usually women more than 50 years of age. A laser peripheral iridotomy may be required. Capsulorhexis during cataract surgery can be challenging in eyes with LAZ due to a small zonule-free zone. When the zonule-free zone is more than 5 mm, the capsulorhexis can be easily performed inner to the insertion of the zonules on the anterior capsule. In case of segmental zonules, the capsulorhexis can be done by including the segments in the capsulorhexis as shown in this video clip. In eyes with complete long anterior zonules, a 5 mm capsulorhexis can be performed safely by modifying the capsulorhexis technique as shown in this video clip. A cystitome is fashioned with a 26 gauge needle and the capsulorhexis is started. A slight extension is noted due to the pull of the long anterior zonule. It is cut using the cystotome bevel. Here you can see the flap being pulled by the pigmented long anterior zonules. This prevents the progression of the capsular excess flap. These long anterior zonules are exerting a pull on the capsular flap. They can be cut with the bevel of the cystotome needle. Once this is done, the capsular excess can be continued, and this technique can be repeated whenever a pull by the long anterior zonules on the capsular flap is noted. A subset of LAZ eyes are associated with late onset retinal and macular degeneration. They require genetic counseling and family screening. Retroillumination helps in identifying long anterior zonule. These eyes require intraocular pressure monitoring, gonioscopy, ultrasound biomicroscopy for the pathophysiology of angle closure. Phacoemulsification can be performed safely after modifying the capsular excess technique. Investigation for associated late onset retinal and macular degeneration needs to be done. Genetic counseling and family screening may be required.